Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Haidar Al-Hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hello Angie, how are you today?
I'm good, thank you, Haidar. How are you?
I'm very well. It's lovely and sunny. For some reason, we always talk about the weather when we start this podcast. It's just so British.
Well, the sun makes you feel good.
Yeah. I mean, I'm an external person, so literally, if the sun's out, I'm buzzing. If the clouds are out, I'm not. But hey, that's just the way it goes. You've done so much, Angie. Like, where do we start? Where do we start with you?
Oh, I don't know. Where would you like to start from your perception of what you think I've done?
So, why did you start in healthcare?
If do you want me to be really honest, I started in healthcare because at the age of 17, I didn't want to do A-levels. And my aunt saw this new program, a new course in podiatry, which is where podiatrists could start to do foot surgery and biomechanics, etc. And so it was her suggestion that I looked into doing that. And so I applied, a bit like the situation we have with young people now. I couldn't get a grant. And so because I'm of Irish background, the Eastern Health and Social Services Board said that they would pay for me to train, provided I went into the NHS after training for 3 years. And that's how it all began.
And what was that like, doing the training?
It was interesting. It was a flagship college that was teaching these new techniques. It was very different. There was a lot of focus on it because it was seen as radical, having so people that hadn't gone down the medicine route starting to do surgery. It was quite different, and it was doing that course for 3 years and then taking up a post in the NHS was a big culture shock for me, because at that time, in the early 80s, the NHS weren't ready for podiatrists at all. And so I came in and did quite a basic clinical role, and then made it my purpose to become a manager, so that I could start to shape services and bring them into the 21st century.
When you say cultural shock, could you tell us what you mean by that?
Well, I suppose at that time, long waiting lists, quite a lot of disjointedness, so there wasn't integration in care per se, quite a lot of silo working, you did everything. So I remember my first day being handed some diaries, some waiting lists, and go and book these patients in and go and see them. So you did everything. There was no admin support. There was no sort of central organisation to it. And I must admit, some people had been on these waiting lists so long they were deceased, and so it took me a while to work through all of that. And quite antiquated technology, not very much prevention happening at that time.
And what was the first thing you did after that?
After that, well, I suppose the thing that did really change and shape my career was becoming a head of service, and at that time also spending a year at Rolls-Royce studying the Japanese approach to organisational development. And that's at that point where I was introduced to the work and theories of W.E. Deming and Walter Shewhart. And so Walter Shewhart was very much about measurement and how you measure things so that you know how they're working. Deming was very much about how you need to manage processes and measure how well they're working, but balancing that with how you lead people and develop people and empower them. So he was obviously about systems working, and the fact that the less rules you put on a system, the better it will work. And he had a great saying that the harder you push the system, the harder the system will push back. And I think we see that today. There are so many rules, so much scrutiny. If we look at the governance from like CQC, often organisations spend more time preparing for the CQC than they actually do in improving the quality of the service for the patients and for the staff. Energies are pushed because the system's being pushed, the system's pushing in a different way. So that really changed, that shaped my career, if I'm honest. And I was able to make a lot of service improvements across the whole of the community trust after having that experience. Although when primary care groups were first introduced in Derbyshire, I then chose to walk away because I could see that the way that they planned to construct them wasn't going to deliver the care to the quality that it had previously. So I couldn't stay and watch it be dismantled.
In what way did you see that? I mean, how could you explain yourself?
Yeah, because at that time we did very much work as a whole system in Derbyshire. And when I say whole system, there was a lot of fluidity between the acute trusts, the mental health trusts, social services, general practice, the community. So we had finite resource and workforce that was maximised by the way that resource and worked for the whole. So there weren't solid boundaries as there are now. So once NHS trusts came in and primary care trusts, we saw a lot more division. So in Derbyshire at that time, they thought they could just take, for example, the community trust, divide it into 6, and then that would serve the 6 PCG, PCT populations, where actually what you needed was fluidity across the greater population footprint, which is what we're going back to now with the integrated organisations and primary care networks working at a population level, and everyone focused on that population.
And it's quite interesting because you've got places like Manchester, which there is a devolution of systems. Tell us your experience of that, and has that changed your outlook as well in terms of healthcare delivery?
Yeah, definitely. I mean, I've had 2 experiences of working in the Northwest. One was actually at Central Manchester Hospitals, which is a large trust, mix of medical, surgical and tertiary, as well as community services. And I think the devolution impact in the Northwest has meant that they control their destiny, and they have had the ability to shape services and focus them on what's best for the population for some considerable time. And Central Manchester, have a fabulous chief nurse, Cheryl Lenny, who has led a lot of that patient-focused service improvement, particularly in the Central Manchester area. Trafford, they have embraced system working, and they had the ability to test different approaches. I work with Trafford in developing care coordination through a call centre. So nurses based in a call centre, people who are perhaps vulnerable and at risk of needing emergency services, frequent admissions, attendances at hospital, were registered with a team, and that team proactively supported them, so with wellness calls, and also the individual or their families had the ability to call the care coordination team if they thought that the person needed extra support or were in decline. And so this telephone centre, these nurses in the telephone centre could work out with the individual what support was required proactively. So they didn't have to go through what I tend to call the washing machine, in a lot of areas where if somebody's going to a crisis point, because there isn't a central coordination area, they may go to their GP or they may phone 999 and they go to A&E, there's the 4-hour pressure, maybe get admitted when it's not the best thing for them, rather than having that proactivity out in the community and ability to work through what would be best for somebody without having to go round that loop. I do remember in particular one individual, it was a daughter who phoned in one day while I was there, and she was in tears and her mum wasn't well and the daughter was at the end of her tether, but the coordinating nurse that she spoke with was able to work through and understand what was wrong with this woman's mum, arrange for the doctor to prescribe some antibiotics, for the community matron to go in, and also for 5 days support to go in to support her mother, to give the daughter a rest. So that is very much proactive care, and I think in Manchester and Trafford they've had the opportunity to test those things that I'm not so sure other areas have, because I think other areas up until now, and the integrated systems I think will probably hopefully change that. It's been a one size fits all, So if it's come down from above, this is what you'll do, then you have to do it, rather than looking for that population. But we know that going forward, I think it's fantastic that we're getting now back to designing services for populations and how services need to work together to support those populations proactively.
Mm-hmm. And as you said, it does boil down to strong leadership. They have a massive say in this. Absolutely.
The leadership comes in, I think, particularly in holding nerve, because if you want to implement a new way of working, because people are busy delivering today, the service today, the appointments today, etc., you need strong leadership to help keep on track of going to the future and future delivery. And as I say, it's not linear. It won't happen in a linear fashion, but keeping that nerve and that sense of direction of where the service will actually go is so important.
How can we develop that nerve? How can we develop that passion? How can we develop that energy? Given that some of us are early in our careers and some of us are late in our careers, and yet we do need that strong leadership quality.
Absolutely. How do we develop it? I think there is so much pressure on daily delivery, and that whether it's the scores on the doors today, how many people have not, are stranded in hospital today. And looking at all the time at that short-termism, rather than actually over a period of time, how can we get to where is needed to be, allowing that, say, maybe this week and next week, yes, we will still have too many people who have, been delayed in hospital, but actually looking at how do we get to the end goal. How do we do it? That is the challenge, because maybe it's so.
I mean, let me ask you this question, Angie. How do you develop strong leadership skills and quality in your work? What makes you such a strong leader?
What makes me such a strong leader? I think I try and apply the looking and reflecting at every situation and every day, so that let's plan something, let's do it, let's reflect on it, and then if it's working, let's embed it, let's do more of it. If it's not working, what can we do tomorrow that is going to make a difference? So actually having that, that quick change cycles, and base it on fact, and not. It's really important not to take knee-jerk reactions to something. It's really important to do that analysis if you're moving through improving and changing something. I mean, for me, I'm a really strong believer in starting each day, if you're going through an improvement journey, with a brief and a debrief. Actually, it's no different to, a ward working well, a general practice working well, a theatre working well. Starting out with that, what are we going to do today, and checking in at the end of the day, what went well, what could have gone, what didn't go so well, what can we do tomorrow to make that better. So it's about having a learning approach. I think it's really, really important. No such thing as failure, only feedback.
And that's quite difficult to sort of accept, given that we've all been educated to really fear failure. I mean, that's how I was educated, going through the whole medical system, and even in life, you sort of run away from failure. You fear it. That's a reality of things. I mean, the soundbite says otherwise.
Yeah. I mean, I think if people fear failure, and if they're made to fear failure,
it's not good.
It affects how they think.
Yeah.
It affects their behaviour. It probably makes them fail more, because of that fear. I think what's really important is to try and design things so that people do not fail, or fail less, or come across situations where something didn't work so well. That's the whole patient safety agenda. That's how it should be.
Yeah.
It's very much what high reliability organisations do. So the airline industry, petrochemical industry, if they fail, it has a high cost in terms of life and finance, in everything. So I think, having that approach to trying to prevent people failing, or getting something wrong is really, really important.
Mm-hmm. Mm-hmm. And going back to strong leadership, I think something that we talked about previously is the process of listening, and that's something that you're good at, and something that you've been a fan of for a long time.
Oh, absolutely. And I think before we started this podcast, we were talking, and we said, I've really become passionate about, we've got 2 ears, 1 mouth for a reason. We need to listen more, talk less. And if you think about a lot of the meetings that take place, people are, they've got their agenda, they know what they want to say, they want to get their point across, but are they actively listening to each other? If there's good active listening in a constructive way, then actually I always say knowledge lies between heads. So if you can build a conversation and actually you can come out with, you might have an idea and somebody's got a slightly different slant on it, but actually through a constructive conversation you could come out with an even better idea. And so it's embracing that as an approach, and letting people have equal airtime. And embracing diversity of thought, diversity of approach. Good teams have a good mix of different styles, different thought patterns. If we look at Edward de Bono, he wrote in his books The Six Thinking Shoes, The Six Thinking Hats, all based on the fact that people think in a different way, and how do we manage that process of thinking so that actually we get good outcome for the team, for the organisation. And Nancy Klein the same with her work on her thinking principles. How do you set create the environment, the time to properly have a discussion, to think something through. It's so important, and we don't do that very well at all.
Yeah, I'm a great fan of Nancy Klein's. I've read most of her books, and I actually love the way she writes things. It's just so clear, and it's gentle. It's gentle to the brain.
Absolutely. By being kind to the brain, the blood flows better to the brain. If somebody's fearful and in a stressful situation of a meeting, we have the fight and flight response, don't we? So the blood flows away from the brain to where it needs to be for that flight approach. When actually, if somebody is in a less stressful situation, an appreciative environment where actually, there is no stupid question, there is no stupid thing to say, there's just much more exploration of why people think in a certain way or believe in a certain thing, then we'll have a much better outcome. And I think it's definitely something that, for me, we need to apply much more in the environment that I'm used to working, which is healthcare.
Yeah, which is a very, very stressful place, no doubt. And having that whole aura of just sort of sitting down and listening to other people's views, and just having that sort of kind presence.
Absolutely. And it works with team colleagues, managers to their, I hate the word subordinates, but the NHS is hierarchical, as well as the clinician to patient. There is a fabulous doctor who you may want to talk to at some point, Haidar. You might come across him, Gordon Caldwell. And Gordon applies, or I've seen him apply, airline approaches, so the safety approaches to his ward rounds. But one of the things that struck me most with Gordon is his sensitive and appreciative conversations with patients. How he constructs the conversation, takes the time to plan the conversation before he gets to the bedside with his team. The outcome all round is so much better, because he allows the patient and the family to have the airtime. See the person, not the condition. So it's not the heart attack in Bay, whatever, but it's the man who used to be the cameraman on whatever film who just happens to be in hospital, So it's fascinating in how he does that.
Yeah, it's having that personal touch, isn't it? That sort of, that spirit side of things rather than just the physical side of things.
Absolutely. Because, we're all spiritual beings, aren't we? It matters to everybody, you know?
Yeah. Yeah. Well, I mean, it's been absolutely fascinating. We can talk for hours and hours, to be honest, because you're a lady with much experience. Give us sort of 3 words of wisdom for people who are working in healthcare. What would you advise them in today's interesting, turbulent times?
Oh gosh. Support each other. 3 words. Yeah, support each other. Be kind.
Yeah. Wonderful. How can people get hold of you, Angie? What's the best way?
Well, I've got a website I'm reconstructing it at the moment, so it's got a few gaps in it. But they can look at www.carebydesign.org or email me on Angie@carebydesign.org.
Thank you so much, Angie. It's been great.
Thank you, Haidar. Thank you.
Thanks for listening to this installment of the Surgical Spirit podcast. For all the latest in the world of surgical spirit, don't forget to follow on Twitter @The Third Eye Doc and catch me on Facebook at the page The Third Eye Doctor. You can visit the website at www.thethirdeyedoctor.co.uk for more information on the work that I do. And please send us feedback and questions and suggestions for the podcast. It's always a pleasure to hear from you. I've been Dr. Haidar Al-Hakim, and I'll see you next time.